And I now have the privilege, really, of introducing to you this esteemed panel of doctors involved in so much important research in the MS field. And so starting to my left is, and to your right, is Dr. Frohman, Dr. Gilmore, Dr. Salzer, and Dr. Coetzee. And I am delighted to have all of you all here. So let's get this discussion started. The one thing I will say is we realize that most of you are not researchers or doctors, so we're going to make sure that this is a conversation that you can join, that you can understand, and more importantly, that you can take back to others, so you really know what's on the cutting edge in the field. So it's so good to see all of you all here. I'm looking forward to this. Dr. Frohman, why don't I begin with you, if you don't mind? You really have a unique perspective on all of this. You're an MS doctor who also does research, and I know how rare that is. But you focus on rehabilitation and symptom management. And anybody who has MS knows the symptoms are the things that you really want to manage. How do these two areas kind of work together for your patients?
Yeah, well, it's a fabulous and very important question. You know, for many people, not just patients and families, but also providers that make up the care team, initially, there's so much focus on, do we have the right diagnosis? Are you 100% sure? Before we talk about living with it and managing symptoms, initially the objective is to make sure that the working diagnosis is as accurate as possible. But I got to tell you, for most people today, because of what we've learned, the application of advanced and very sensitive imaging technologies, the hardest and most formidably challenging component of MS as an experience for the care team or the patient and family has now in a way been somewhat removed from diagnosis and the early disease-modifying therapy. That has become much more straightforward than it's ever been before.
Meaning you get an answer pretty quickly?
Much faster than we used to. We would very commonly have patients come in and say, you know, it took 10 years to confirm my diagnosis. Today, the stakes for early diagnosis and the application of treatment could not be higher. But once we've decided, we think this is the appropriate working diagnosis, these are the disease-modifying therapies, then the future continuity of care is mostly telescoped on how do you live with this disease. And that is really the thrust of your question. And I think if you care for people with MS, after diagnosis and disease-modifying therapy, we have to recognize that the landscape of symptoms that can be experienced by patients and families is incredibly broad, which also means now we need providers, physicians, nurse practitioners, PAs, nurses, social workers, who are more familiar with not only pathophysiology, diagnosis, but what kinds of questions do we need to ask our patients and their families about how has life been changed in some way, working life, home life, raising children. I think the magic for our program and other programs around the country, and it's great to be here in Dallas, is that we have assembled a multidisciplinary team. It's a village of people who are telescoped on that patient, but also that family. So we can systematically go through, are there symptoms related to drug treatment itself? There may be. Are there problems with bowel, bladder dysfunction, sexual dysfunction, skin integrity problems? Do we have the right chair? What are we doing about these resentful children who are making you and everybody else crazy? We bring them to the clinic, then we make them a little crazy, and then they go, wow, I'm doing this to you. So I think it's critical to look at MS, to do it well. Number one, the patient must recognize, I have MS, but I'm not going to allow MS to have me.
Exactly.
And part of translating that from speak into action is to be at a place where the care team is focused on the broad landscape of symptoms, what can be done. And many, many things can be done. And by the way, it's trial and error. There are things we do that don't work, but we'll go to the next step. The only things we can promise is never to quit and always to try.
All right, and that leads me to Dr. Gilmore. And you do research in some, and bear with me here because I'm going to try to explain it, in the fields of immunology and neurobiology, also known as neuroimmunology. And it basically means you're trying to figure out how the brain and the immune system work with each other and what it is about our immune system that is so out of balance in MS. Can you talk about specifically why this is so crucial in understanding and now treating MS?
Certainly, thank you very much, Melanie. We know that MS is a disease in which there's injury in the central nervous system, which consists of the brain, the spinal cord, and the optic nerves.
Yeah.
And there's also a dysfunction in the immune system, which consists of a lot of different cell types that are mostly important for defending ourselves against viruses and bacteria, et cetera. And the immune system gets dysregulated. It somehow believes...
Dysregulated, that's a nice
So
word.
dysregulated
Yeah.
means that it is too aggressive, and it's too aggressive towards cells of the central nervous system. And so it's able to get into the central nervous system and either promote or cause damage in the central nervous system. So it's very important to know how the two of them interact, and also to understand what is dysfunctional about the immune system
And do you
what
feel
is
you
out of
have a better
balance.
handle on that now than you did, say, even 5-10 years
Yes,
ago?
I think we do. We know a little bit more about how the disease-modifying drugs affect the immune system, how they can maybe reset some of the immune function to make it more in balance and more beneficial toward MS, and how we can sort of understand by studying the immune system in disease-modifying drug-treated patients, what might have gone wrong in the first place.
All
So
right.
very, very important.
So the work has really moved forward, which is
Yes.
good. Now, Dr. Salzer, you are a neuroscientist, so you really target your studies on the brain as well. And I know that you're researching how nerves and the cells that make myelin, you know, that word that we learn when we discover we have MS, how they speak to each other. And I wonder if you can talk a little bit about how that relates to people who have issues with MS.
Sure. And first of all, I want to thank both the Society and the conference to be invited to this wonderful conference, and thank all of you for the support which has made this exciting research that's going on around the world possible, and it's really been essential.
that's so
So thank you. So I would say the first thing to understand is that when we talk about nerves and the cells that make the myelin sheath, they really function as a unit. They work together. And let me explain that. So the nerves instruct the cells to make the myelin sheath. There are signals. And then in turn, once the myelin sheath is formed, it enables the nerves to conduct electricity, the electrical impulses that are critical for communication properly. And moreover, the myelin sheath also is critical for the survival of those nerve fibers. So when you lose the myelin sheath, the nerve fiber is much more vulnerable over the course of the disease. And we know that an important and still unsolved problem in MS therapy is neuroprotection. So for
And does neuroprotection mean actually regenerating some of that myelin sheath? Is that what you
well,
mean?
that is the gold standard. That's the expectation, is that if we could regenerate the myelin sheath, we would protect those nerves from undergoing damage. But for a patient with MS, I would say that in an acute attack, when you lose the myelin sheath, it's manifested as an inability to conduct impulses properly. Undoubtedly, the inflammation that's going on also contributes to the interruption of conduction. And then, of course, over the long haul, patients that have the disease for decades, even when the inflammation subsides, those nerves are vulnerable, and we know, and we've learned over the last decade or so, that there's progressive degeneration. So that's, the communication between these two cells is critical, and to be able to understand it is critical to come up with new rational therapies.
Well, I ask you the same thing I asked Dr. Gilmore. Do you feel as though you're really making some advances there, that you're just a few years away perhaps from that gold standard?
Well, I would be hesitant to predict timelines, but I feel extremely encouraged. I think it's an extremely exciting time to be in the field because of the advances that are going on. I don't want to say breathtaking, but it's close to it.
All right, well, we'll settle for that. And it's my job to push you on timelines, by the way.